Thank you, Anup. That was a wonderful talk, and I hope you all will share my enthusiasm about the future of neonatology. Because these are the people who are going to help us answer critical questions in neonatology, take a focused approach to a small but critical area, and then stick with it, stay with it until we have the right answer. Too often we are impulsive, we are impatient, we don't really get to the bottom of the problem. So this second talk, um, I had been asked to talk about antenatal steroids in particularly the late preterm infant. And I'm going to sort of start off by saying that if you look at global neonatal mortality numbers, there are about 120 million live births globally, 13% preterm births. There are 10 million late preterm births, 10 million late preterm births. And so anything that we do with this population has a major impact on overall morbidity, survival, and long-term outcomes as well. And that doesn't mean that we don't need to continue to work with babies at the edge of viability. The 24-weekers, 26-weekers all count, but really a lot of developing world still struggles with making sure that this population of late preterm babies get the best possible care. Now, nearly 50% of late preterm births are delivered by cesarean section worldwide. And so remember from my previous talk that if a baby is born by cesarean section and is preterm, then the cards are stacked against the baby with proper neonatal transition. And so sure enough, 1/3 of these babies develop respiratory distress. They have problems with lung fluid clearance. And a large number of these babies had a C-section before they were ever exposed to any labor. And so there was really no way for the mother and baby to connect and start reducing the lung fluid production. And that's why there is a higher incidence of transient tachypnea. And this is shown here that if you look at planned vaginal birth and you look at cesarean birth, it's only around 39, 40 weeks gestation that these two curves start to switch. This is respiratory morbidity. And so you see there is a large gap between higher respiratory morbidity in babies born by C-section. The more premature you are, the wider the gap between planned vaginal birth and elective cesarean birth until you get to about 40 weeks gestation. And the reason is that ability to clear fetal lung fluid peaks at term gestation. Surfactant maturity is not an all or none phenomenon. And that developmentally regulated proteins like ENaC, I showed you in my previous talk, only start expressing themselves when birth is imminent. And obviously there are changes in pulmonary vasculature as well. So it was 34 years ago that this landmark study by Dr. Liggins was published in Pediatrics in 1972. It was an RCT, about 200 patients enrolled, 12 milligrams of betamethasone in 2 doses, 24 hours apart. It showed a dramatic reduction in perinatal mortality and a reduction in incidence of RDS. Okay. Clear, simple intervention, very cheap. One would have thought that either we would have very quickly replicated the study, or if the data was so convincing, we would have adopted the study. Guess how long it took to start using antenatal steroids in preterm labor? By 1994, the NIH got alarmed in saying that the effect of corticosteroids on fetal maturations is there, there was a meta-analysis of 15 trials which showed ACS reduces mortality, reduces RDS, and intraventricular hemorrhage in preterm birth, that benefits extend all the way up to 34 weeks gestation. And I'll explain to you why there was no effect shown after that. Not limited by any other factors, and benefits were greatest after 24 hours of starting the dose. But even babies who got exposed to steroids for less than 24 hours showed benefit. Okay, so there's no reason, if you look at all of this, to say that there should be a delay. Well, the NIH consensus statement showed that in premature preterm rupture of membranes, ACS showed benefit. Whether it increased the risk of infection or not is not clear, but the benefits outweigh the risk of infection. The follow-up in 12 years after treatment, in children 12 years after treatment, showed no delay in physiologic growth and psychomotor development. And I'll show you, perhaps I may have that study. There's a 30-year follow-up in these babies now, which shows no neuromotor impairment at all. And ACS therapy resulted in substantial savings to our health system, about $2 billion annually. Well, why is it that glucocorticoids are so effective or so helpful? Well, for one, they stimulate cytodifferentiation in a variety of tissues. For example, in the intestine, they help with maturation of the glands and villi and improve digestive function. In brain, they accelerate myelination and functional maturation, preventing ischemic damage, also preventing intraventricular hemorrhage. The reason why there was no recommendation for use of steroids after 33 weeks gestation was twofold. One, Dr. Liggins did not study gestations where RDS incidence wasn't that high. And subsequent studies that tried to look at this took the same endpoint as Dr. Liggins and said, we are going to use antenatal steroids in preterm birth or suspected preterm birth, but the outcome is going to be either RDS reduction or mortality. Well, those are not the right outcome measures. Why? Because at 35, 36 weeks gestation, the incidence of RDS goes down dramatically and mortality goes down pretty significantly. You would have to, if you're a clinical trialist like Dr. Anup Kataria, you know that you would have to have a very large N to be able to show a reduction in death rate. And so studies after studies didn't really pay attention to this problem, whereas many of us who were deeply involved in looking at respiratory transition after birth were very vocal about saying, if it works until 33 weeks gestation, and we're still seeing that much morbidity in 34-week gestation babies, why shouldn't it work in 34-week gestation patient? Even if there is not clear-cut RDS, but a mixture of TT and RDS, apnea, all of those things. And so it took me 5 years of taking this back to NIH every year to finally get this trial approved. I started in 2005 when the first late preterm workshop was convened by the NIH in the US. And I spoke about our basic science studies showing how giving antenatal steroids or exposing lung cells to even one dose of steroids overnight leads to improvement in sodium and chloride clearance and water absorption. And so this study was published finally in 2016. Cynthia Jamfi from Columbia, from the Maternal Fetal Medicine Network, was the first author, and I was the only neonatologist on this multi-center study, and I had the great pleasure of reviewing every single neonatal chart that the study centers had issues about. So, for a basic science person, it was really an experience of my life, looking at how in each center people had trouble figuring out what neonatologists do, because these charts would say the diagnosis at discharge is rule out sepsis, or rule out TTN, rule out transient, rule out RDS at discharge. And so what they were asking me is, since the neonatologist didn't say what the diagnosis was, how do we look at primary and secondary outcomes in these patients? Because chart after chart, neonatologists were very difficult to pin down and commit to initial diagnosis. So the hypothesis in this study was to look at late preterm delivery, administration of antenatal steroids with an eye towards decreasing the need for respiratory support. Now think about this. I was adamant that reducing mortality and reducing RDS or reducing TTN cannot be the primary outcome, and that it had to be a functional measure of what you as neonatologists do every day. And if at the end of the day, the intervention doesn't help improve outcome, I don't care if there's a reduction in TTN or RDS or slight reduction. This one has to be able to show that the need for respiratory support went down. And so the eligibility for this study was to look at mothers from 34 weeks to 36, 7 weeks gestation. I won't go through all of the details. These slides will be available to you after the conference. But if you think about why we looked at babies where we expected preterm delivery, we really wanted to make sure that these babies got enough exposure to antenatal steroids, that at least 24 hours, ideally 72 hours of exposure. I think this is important because as I share with you results, you'll see why planning a study properly is critical in making sure that you don't have negative results later on. So we excluded moms with PPROM, with chorioamnionitis who were dilated beyond 8 centimeters. Why? Because we didn't want them to deliver in 4 hours. That would lead to a negative study result. We needed mothers who would at least hold on to their pregnancy for a decent amount of time. Any pregnancy where an emergency section would be necessary. There were also other exclusion criteria. Gestational diabetes was a very tough one. We were convinced, as a neonatologist, I was convinced that we needed to study diabetes or diabetic pregnancies, because you all know that in diabetic pregnancies, the risk of respiratory distress in the baby is higher. Do you know why the obstetricians elected to exclude it? Because they said that the study will get unmasked. That when you give steroids to a mother who has gestational diabetes, if you give them steroids, then the blood sugar will go up. And so it's no longer blinded study when that happens. And we as clinicians are curious people. We always want to know, what did this patient get? And then try to predict based on the algorithm that is being used for randomization, what the next patient is going to get. And I go back to my days in Chicago when we were doing surfactant trials. You knew right away which patient got surfactant and which patient got air placebo, because but yet there would be discussions in the NICU all day long about what patient got what. And so this was randomization, 1-to-1, 2 doses of betamethasone, 24 hours apart, or identical placebo. And we made a perfectly looking placebo to give to these patients so that one could not, looking at the syringe, ever tell which was what. Tocolysis was not employed in this study, and analysis was by intention to treat, which means once you assigned a mother to one arm or the other, we kept them there. 17 maternal fetal medicine units participated in the study, and the study took about 5 years, only because during this time, in the middle of the study in 2012 or late 2012, there was an outbreak of a fungal infection, aspergillosis, related to compounding pharmacies. They were giving steroid injections in the spine, and because of that risk, FDA shut down all compounding pharmacies for some time, and our placebo was coming from a pharmacy. And so we had to stop the study for a year or year and a half before we could reopen it. So this is the primary outcome, composite outcome, looking at oxygen need with FiO2 greater than 30% for at least 4 hours, CPAP or high flow nasal cannula for at least 2 hours, mechanical ventilation, ECMO, stillbirth, and neonatal death, all measured within the first 72 hours of life. Secondary outcomes included severe respiratory morbidity measured as oxygen need of greater than 30% for at least 24 hours, and CPAP or high flow nasal cannula for at least 12 hours. This is how we randomize our patients. Almost 3,000 patients. Our two arms look very similar. We had unbelievable study control. 2 patients lost to follow-up in this group, 2 patients lost to follow-up in this group. And ultimately, we had 1,400 plus patients in betamethasone and 1,400 patients in the placebo group to analyze. These are the baseline characteristics. If you look at the gestational age distribution, our intention was to have maximum enrollment at 34 weeks gestation. We only got 26%. Now, the higher the number of 34 weekers in the cohort, what will it do to the power of the study? The power of the study will go up because as babies are more and more premature, their risk for respiratory distress is higher. Therefore, if your study intervention has impact or it's working, then it'll lead to a greater effect. And if you have a large number of babies at 36 weeks gestation, where the need for respiratory support is already low, then the effect will be lower. But also, this is a trial entry. Now look at the gestational age at delivery. What you see here is a good number of these babies, 40% here at 36, 13% at 37, 38 weeks, and about 4% at 39, 40 weeks. So a lot of babies did not deliver early enough for us to see a huge effect. But still, you see how the numbers are important. And then from time, if you look at the study drug, 60% received 2 doses, 40% received only 1 dose of steroid because they delivered. And from time of randomization to delivery was 33 hours in betamethasone, 30.6 in placebo. Again, no difference, but all these to show that the study had high fidelity throughout. Here are the results. When you look at primary outcome, we had a nearly 3% reduction in in the primary outcome, placebo at 14.4, betamethasone at 11.6, p less than 0.02, number needed to treat of 35, which means that if you treat 35 mothers with betamethasone, you will have at least one baby who will not require this level of respiratory support. When it comes to secondary outcome, which was severe respiratory morbidity, the effect was even more dramatic. That there was a 33% reduction. So from 12.1 to 8.1, that's 4% absolute reduction in respiratory morbidity. And that was a highly significant result with a number needed to treat of 25. And then we looked at all other secondary outcomes, which is where I spent a fair amount of my time during that time. TTN reduction as we suspected, BPD reduction, RDS, TTN, apnea combined significant reduction, and surfactant use also went down in betamethasone group. Very few babies had an IVH in this, and that's why I think it's really important to see what type of outcome measures. Had we picked neonatal death as an outcome measure, this would have been a negative study because there were no deaths literally in the entire cohort, yeah. And then non-respiratory outcomes are listed over here. One non-respiratory outcome of note is that we had a higher incidence of hypoglycemia, 24% in betamethasone group and 15% in the placebo group, a highly significant result. And we spent 3 years after the original study looking at hypoglycemia, and I'll share some results with you. So what we found for hypoglycemia was that the time from randomization to delivery was shorter in the hypoglycemia group versus no hypoglycemia, but the median length of stay in the NICU was actually shorter in the hypoglycemia group. We also went back and looked at the definition of hypoglycemia. We chose a cutoff of 40 milligrams per deciliter. A lot of centers now are using 30 milligrams per deciliter. If we had chosen a lower cutoff, the incidence of hypoglycemia, of clinical hypoglycemia in these babies would have been a lot lower. And so to summarize, what we found was that antenatal betamethasone given to women at high risk for late preterm birth significantly decreased need for respiratory support, decreased the relative risk for prolonged NICU stay, transient tachypnea of the newborn, need for surfactant, and BPD. There was no difference in maternal or neonatal infectious morbidity, no difference in birth weight or small for gestational age. It was beneficial even in the absence of tocolysis, which means we did not, unlike other preterm births, at 28 weeks, if you give antenatal steroids, you always tocolyze the mother to make sure that the steroids have time to have an effect. In this study, we did not tocolyze any mother as part of the study. Obviously, we made a strong recommendation that postnatal glucose assessment is critical. Now, the factors which may have influenced efficacy, as I have shared with you in this brief talk, is that only 26% of the study population was at 34 weeks gestation, which is where we expected 50% to be. 40% did not receive a full course of steroids. The average time from randomization to delivery was 33 hours, not 48 hours or 72 hours, and 56.8 delivered at or after 36 weeks gestation. Since then, unlike most studies where it takes sometimes a decade, 2 decades for a single study to change practice, this study got published in February of 2016. In April, the ACOG came out with a recommendation that it's a low-cost, highly effective intervention that should be implemented across the country. A Canadian society came out with the same recommendation, then European Society for OBGYN came out with the same recommendation. Clearly, what was missing in this was that developing countries where the burden of infectious diseases and chorioamnionitis is a lot higher had not been a part of this study. And so then studies started coming out asking whether or not we do, what do we do as we do implementation of late preterm steroids. The recommended practice is that we did not study twins, so we don't give it to twins. We did not study pre-gestational diabetes. Moms with chorioamnionitis should not receive late preterm steroids, and do not give if delivery is not likely before 37 weeks gestation, because then you're only exposing the mother and baby to an agent that is not necessary. What you really see in actual practice is different because a lot of places now have begun using steroids in diabetic pregnancies. And we have just finished doing a secondary analysis in diabetic pregnancies as well. If you just look at the cost factor, the savings between betamethasone and placebo are very significant. This was a study that was completed as part of the secondary analysis by an investigator from Boston. Long-term outcomes, what do you do in developing countries? I'd love to hear from you during the Q&A hour or time, what you are doing in your local area, whether it's in Curacao, in Colombia, or other parts of South America, because in each of these areas, there is need. So I feel that we rely on initial RCTs. What we forget is that an RCT is just the beginning of how we approach clinical medicine. That ultimately each center needs to have data collection, which informs locally what your center is because there are practices that are unique to each area. And that is where there is great need to make sure that you in your area are tracking outcomes in late preterm gestation steroids, antenatal steroid delivery, and are making sure that if there are infectious complications or if there is any other complication that you record it and you adjust things accordingly. Now, two things I will mention to you. That in the 40 years nearly since the ligand study, we have not done another study looking at the dose of steroids. Dr. Liggins randomly used the 12 milligram dose of betamethasone, a combination of two compounds in it. And we've not really looked at whether or not in preterm babies, a smaller dose may be actually equally effective or even more effective. Why should we use 12 milligrams as a factor? That's one question. The second question, obviously, is that we use betamethasone. We have not really looked at dexamethasone as an equally effective agent. In my lab experience, dexamethasone has a much better genomic profile that turns on many more genes, and so it'll remain to be seen how that is done. What I would mention to you is that, again, in each area, there is an opportunity to optimize the way we measure outcomes. So I'm mentioning this one study to you only to say that we don't do a good job looking at long-term outcomes. That when we look at cord blood milking or we look at a delivery room intervention, We just look at very proximate outcome. Well, what we did in my state in Georgia is we approached the health department and said, we got this huge database with every hospital contributing to vital statistics and to hospital discharge data. The Department of Education has data on all of these babies who survive from first grade to SAT exams. Can we link these two records? All we have to do is, if I knew back to the day when Carlos was born, what his birth weight was, yes, long time ago, what his birth weight was, and if he had any neonatal complication, and then from his education records, I know how he did in his first grade, third grade, fifth grade, 11th grade, SAT exam, college. You know, that is the proof of the pudding, right? And so this is what we began doing. We looked at executive learning ability, math scores, reading scores in extremely premature babies, moderately premature babies, late premature babies, all based on school data. Now, you may argue that this is not probably the best or most accurate way of doing things, but it avoids having to spend millions and millions of dollars looking at milestones, early milestones, and not knowing really how those babies do from when you measured those types of developmental outcomes to how the child is doing in school, because that's ultimately where the final product is. So I'll end here by saying that as I look at the sunset of my own career, as I'm starting to look at stepping away, retiring, I'm more and more convinced that we are too obsessed with evidence, that Mother Nature didn't say that you need an RCT to show you whether or not putting a drop of colostrum in the mouth reduces mortality or somehow dramatically improves some physiologic measure. That's for you all to determine and do and measure. It's a single center. It's all about tracking those types of things and doing those things rather than expecting that someday the NIH or some world body will start looking at every single problem that we're facing and solve those problems for us. And for us to not have a clear single definition of hypoglycemia, not have, up until recently, definition of hypoxia, where do we keep oxygen saturations? I mean, I finished my training 40 years ago. And for us to still be struggling with these basic issues really makes me sad sometimes. Having said that, there is no other area in medicine where such dramatic improvements have occurred. And it's really largely because of all of you, the way we in the ICU provide care and the way our nursing colleagues have really picked up from where we left medical care. So thank you again. Look forward to questions from you. Thank you.
Thank you so much, Dr. Jane. And before to start our session of questions, I really think that as Dr. Jane and Kateria told today, I really think that be the change that you wish to see in the world. I really think that in our hands is all the steps that we can do to improve the future of our babies. Questions? I will start with the okay, translation.
Yeah.
Stay okay, where is? How much PEP is safe to use during resuscitation? Dr. Katiri?
Me?
Or I don't-
That question will be great for that man in the back too, because he'll talk about PEEP quite a bit. So I think it depends on, there's been studies going of PEEP as high as 12. But as far as a lot of that's being still studied right now. So like in the US, it's more commonly to go up anywhere from 6 to 8 in our preterm babies. During resuscitation, we don't tend to go higher. I know in Australia, they go up to 12, and there's some studies that they're looking at higher PEEPs. But do you want to say what you do?
I was going to ask Dr. Kessler. Marty, you want to just come up here and because, all right, what do you recommend as an ideal PEEP for delivery room resuscitation?
I think it's not a single number. I think it depends somewhat, and it's a dynamic situation, right? So you might need to titrate the PEEP. And there's in fact a study that David Tingay's started up in Australia that's looking at dynamic PEEP as a prospective randomized multicenter trial. With the idea that the fixed PEEP that most people use, which may be 5 or 6, may not meet the baby's needs immediately. And if the baby's oxygenation hasn't improved and heart rate hasn't improved, you probably need more. Once the lungs open up, as you know, they become more compliant. Laplace's law comes into play, and once the lungs become more compliant, you probably need to back off on the PEEP. So there's no single number. We tend to start around 6 or so and go up if the baby tells us that more is needed, and then back off.
And I think it is important to differentiate between PEEP and CPAP. I think it is, if you're thinking about PEEP, you're thinking about an intubated patient. I hope that most of your patients now you're managing with just CPAP, in which case the numbers that both Anup and Marty emphasized are largely to open the lungs and back off.
Next question. What about DCC in infants with age incompatibility?
Yeah, that's a good question. So there's a study by Gavadam it was in pediatrics a few years ago that looked at this question. So randomizing babies with RH incompatibility to delayed cord clamping or early cord clamping. And interestingly, the babies that had delayed cord clamping, even with RH, needed less blood transfusions than those with early. So the idea that additional antibody would be going into these infants with delay didn't seem to prove to outweigh any risk because they were providing this additional blood. So I cite that study a lot when people are worried about blood incompatibility and delayed cord clamping.
Next question, really interesting, I think so. Could you please define stimulation?
Yes. So we define, or we use stimulation as mostly the obstetrician rubbing the infant's back. It's not flicking the toes or the ears or causing any pain in the baby. You're really trying to rub their back while they're being connected to the cord or even after birth.
Next question, could the delayed cord clamping to have some side effect, maybe polycythemia, hyperbilirubinemia, that being severe can throw off salinopharesis or exchange? Do you have any experience respect of?
Right. So that was obviously one of the biggest concerns initially when people were adopting delayed cord clamping. You know, when you see babies that have very high, I mean, I've done exchange transfusions in the past, but those are oftentimes babies asphyxiated, outborn, babies born, at home, where there's also other factors, hypoxia, cold stress, et cetera. But doing routine delayed cord clamping, there was recently a really large study out of Sweden, over 6,000 babies looking at delays of out to 10 minutes and looking at changes in bilirubin. It did not make any difference whether they were clamped early or late in terms of the risk of bilirubin in phototherapy. One thing to remember is you're perfusing organs, you're perfusing the liver, you might be improving conjugation. So it does not seem from any of the studies, including ours done that we've led, none of them show increased exchange transfusion was a severe adverse event in all of our trials, and we did not see any increases in exchange transfusions for polycythemia or hyperbilirubinemia.
Why not to use ACS for LP twins?
Yeah, Horacio, this is a this is a real important question. The problem is we did not study twins, so that's why we couldn't make a recommendation about twins. The problem with randomizing twins was to how do you randomize twins when both fetuses have received the same antenatal steroid. But I do think that many centers or most centers are now starting to use antenatal steroids in twin gestation.
And the complementary question to that is, was there a difference in NICU's admission between groups?
Right. So I did show that there was a statistically significant difference in NICU admissions between placebo and betamethasone. It's about 10% reduction in NICU admission. The reason why we didn't choose that as an outcome measure initially was that in a lot of NICUs within the network, it was standard practice to admit all 34 weekers to the NICU. So whether you have respiratory distress or not, you are admitted to the NICU for observation for 24 hours. And so since both groups had equal number of admissions, we didn't use that as an outcome measure.
Any other?
Can I ask one question before you? Why wasn't there a long-term follow-up built into this study?
For this study, there is. We do have we have an R01 that is looking at pulmonary outcomes and long-term outcomes, which should be, the data are being analyzed and should be coming out soon. Yes, yeah. But it was, funding for these studies is not easy, Anup. And we were just lucky that we were able to conduct a study with nearly 3,000 mothers. Yeah, I still do believe that antenatal steroids are a very safe and effective intervention, probably the most effective intervention in preterm deliveries that we've been blessed with. And I hope that most of you are using antenatal steroids in pregnancies, even down to the limits of viability. People have shown that they are effective.
Yeah, great talks, both of you. Thank you very much. What could be theoretically or practically the drawbacks of using steroids in late preterm infants?
Well, so the biggest drawback would be if you had severe hypoglycemia as a side effect and you didn't have the ability to monitor these babies and intervene. That's the biggest risk from my standpoint. The second risk is that in areas where there is high incidence of PPROM, chorioamnionitis, or phenocitis, giving antenatal steroids to these mothers, particularly if delivery doesn't happen soon after, could increase the risk of neonatal sepsis. Now, having said that, people have asked what is the risk of exposing 10 million pregnancies, mothers and babies to steroids? You remember, when you go down to low gestations, 24, 26 weeks gestation, the number is very small, right? So now you're exposing a lot more mothers to antenatal steroids. The beauty is that when delivery occurs, the baby gets rid of betamethasone very, very quickly. It's that if the pregnancy continues, then the steroid gets recirculated and could have impact on growth and neuromotor issues also. Although that's not been shown to be the case in the Liggins cohort and many cohorts after that. It's multiple courses where in early gestations, you have to give second, third course of steroids. After the second course, the efficacy doesn't get improved and the risk of side effects increases. Okay, so there's, Nigel, there's one more question there. Does the benefit of ACS persist exclusively at 36 weeks gestation? The answer is yes, it does. And in that case, does it explain the hypoglycemia? Yes, it actually, this is a very interesting observation, that it is interconnected. The quicker after giving steroids the delivery occurs, the greater the risk of hypoglycemia. And we actually have done some studies now looking at cord blood that we had saved from these babies. We're looking at what triggers hypoglycemia in the babies that it does. We'll be publishing those results soon.
Any additional questions?
For Anup, in regards to the milking and delayed cord clamping, do you recommend to be used the milking from 28 weeks onwards only, or is there any differences in terms of when to use it or when not to?
Yeah, you know,
particularly in Latin America.
Yeah, I honestly, I was very humbled when I saw the harm signal. I did not expect that. I thought even if there was a theoretical risk of IVH overall, those would be balanced. So I honestly don't know our numbers from, they're literally analyzing them in these 1,000 kids that are 28 to 32 weeks. If I don't see any harm signal, then I would. But, you know, even though there are a lot of studies, 28 and up, that have not shown differences, I think in cord clamping studies, where the problem is we're subject to publication, you know, bias and underreporting. Too many small studies that say there's no difference. And I think that's where we got in trouble with cord milking, is we did lots of tiny studies that said, oh, it's good. And then until you do a large one. So I wouldn't recommend milking yet until I know that it's equivalent in terms of the short term. And ideally, as like you said, we need the 2-year data, which, you know, we'll have hopefully in the next year and a half or so. I think really most of us can do delay. Remember, preterm babies, they're not asphyxiated. If they're not breathing, it's not that they're like a term baby should cry within 15 seconds or so of birth with stimulation. A preterm baby may take some time. They might have good tone, but they're not breathing. They just need a little bit of ongoing time for them. So I don't think we need to milk as much as people think we do in the preterm babies. The term kid who's limp, blue, who's born by a crash section, I don't think stim's going to help too much on that baby. They probably need to be resuscitated, right? And that's where maybe milking can help those babies.
The baby that is premature, that is not breathing, due to asphyxia one, or simply that the prostaglandins are still working on the baby and not letting the baby breathe inside,
Right.
outside.
Yeah, I think it's all this physiology that Lucky was showing earlier. Preterm babies, they're not, you know, looking to start their transition right away. The earlier they are, I'm sure they have higher levels of prostaglandin, and they're not looking to start to aerate their lung as easily as a later preterm infant. So those kids need more time. Yeah.
We have 2 additional questions. Finish. One is, what about more than 2 cycles of steroids is worsening than a single one?
Right. So in this population, the late preterm population, we don't recommend using a second course of steroids. I want to make sure that you agree with that. The second course of steroid is recommended in pregnancies where the first course were done weeks ago and the mother never delivered. And now the worry is that the effect has worn off and you give a second course of steroids. Maybe it started at 28 weeks gestation. Now the baby is 34, 33 weeks gestation, likely to deliver. Most obstetricians will give a second course. Most studies have shown that giving a third course after that is not helpful, that the risk of cerebral palsy and other negative effects on growth and neuromuscular development increase after that.
And our last question of the session, what about those babies that have risk of polycythemia? Delay or milking umbilical?
Yeah, milking is going to give more blood. So if that's not your intention, you should delay. So if you have an infant of diabetic mother, et cetera, those babies that have higher baseline hematocrits, and you shouldn't milk unless the baby needs resuscitation. Delay should be your number one option for every baby when possible.
Thank you so much, Dr. Kateria, Dr. Jane. And thank you so much to all the audience to enjoy with us this session. And I wait you tomorrow. We wait you tomorrow for our last session that will be amazing with the presence of Dr. Kessler that is here with us today too. Thank you so much.